Hello, everyone. My name is Jessica Shields, and this is discussion board 1. So, I want to start off by talking about a time that I was working in the ICU, and most of our patients do get many medications at one time. But I can remember this one patient. They came in with diastolic congestive heart failure with an EF of only 15%. Their blood pressure was 50/40, very hypertensive, and they had Hep C, so they had liver damage as well. The extent of the liver damage was unknown, but they did have elevated liver enzymes. So the doctor started them on a Levophed drip, also known as norepinephrine, to bring up the blood pressure. We use that a lot in the ICU. And it was on the nurses to titrate it to keep their MAP above 65. So he ended up getting maxed out on the Levophed, and his blood pressure was still low. It was still very low. And Levophed acts as a vasoconstrictor, so it pulls the blood from the periphery to the core to try and get the heart to pump better and bring up the blood pressure. So, in addition to the Levophed, the doctors put him on a dobutamine drip as well, and that was to help the heart failure. The dobutamine acts as the inotrope, and it can increase the contractility of the heart. So they put them on that drip as well. Well, when the Levophed was maxed out and the blood pressure was still not in a therapeutic range, the doctors decided to add a neosynephrine drip. So we added that in addition to Levophed to try and bring up the blood pressure. So in the whole mix of it, the patient was very cold because their periphery, was vasoconstricted. Their fingers started turning blue and their toes, and then it ended up going up the blue cyanotic look ended up extending to their extremities. So their arms and legs were cyanotic. The patient was short of breath, and he started having kidney failure. And that could have been pre-diagnosed, but we were unaware of the kidney failure. Whenever he came in, his labs did not show kidney failure. But then after a few days of being on the drips, his kidneys started to fail. So in that case, the doctors added a dopamine drip at a low dose. If you give it 2 mics per kilogram at a renal dose, it can try to help the kidney function. So now this patient is on Levophed, neosynephrine, dobutamine, and dopamine all at the same time. So if you can only imagine the pharmacodynamics of how all these drugs are working in the body and the mechanisms of actions, and how extent this patient's organs and pretty much entire body is handling these medications is unknown at this time. So the patient ended up getting worse overall from a nursing standpoint. He was very he had shortness of breath. He was very cyanotic. The kidneys did not really improve much. He had very little urine output, and he started having seizures. So later that night, after we, got the seizures controlled, the doctor still wanted to keep him on all the drips because his blood pressure was still not therapeutic. It was about 78/50, but the MAP was still like 55. So they wanted to keep him where he was. Later that night, he ended up going into VFib. So we ended up calling a code blue, and we had to start CPR and get him hooked up to the AED, and we ended up shocking him a few times, give him a few doses of amiodarone to try to regulate the rhythm. We ended up getting him back out of VFib, but that happened a few times it was about a 10-minute span. So he ended up stabilizing, but as a nurse, I would like to have a better understanding of how all these medications are working together in the body, and how one medication may have caused the VFib, because I know fatal arrhythmias are a side effect or adverse effect of dobutamine, but mixing all those other medications could have caused the VFib as well. So we can't say that it was the dobutamine, and who knows, the patient might have went into VFib without any of the medications just because he was so sick. So that was one incident where I do remember him being on a lot of very critical drips, and me as the nurse titrating them. And I definitely did do research and looked up each medication and made sure I knew, the basics of the medications. But as from a pharmacokinetic standpoint, I can't say that I was 100% on how everything was working in the body. So with that being said, I do think it is possible that pharmacogenetics may have prevented this patient from going into VFib and kidney failure and all the adverse effects that he was having. By studying his genes, we may have found a link that could have triggered us to give one medication as opposed to the other. Scanning a patient's genes can allow us to personalize their treatment plan and individualize it based on them and their needs and what may work for them. Because as the text said, a patient is not a one-size-fits-all dose. So by scanning the genes and doing the pharmacogenetic workup, we could have prevented this possibly. Because in the PowerPoint, it had an example that one gene produced adverse effects with warfarin or Lasix, and knowing that, you would prescribe a different medication in the same class. So it could have been prevented possibly. by knowing that. And I do believe that it is very important to understand the pharmacodynamics, especially when administering multiple medications, because knowing exactly how the drug is going to work in the body is very important, and knowing the pharmacokinetics of each patient is very important as well. We base all of our critical drips on their weight and their kidney function, so that is the very beginning of the pharmacokinetics of deciding how it might absorb or distribute into their body by their weight and kidney function. And speaking on the liver damage with the Hep C, I was reading that possibly the liver damage, the patient might have had fewer albumin binding sites that could lead to increased levels of the free drug to move to site of action, and that could lead to an enhanced effect of one or all medications, depending on which one is the weaker of them. And since they were all pretty strong drugs, they might have all been enhanced by that. So I'm very excited to be taking this class, and I hope I learn a lot about medications. It will definitely help me in my ICU career. Thank you.